We're going to open up the floor to questions now, and we'll have all the speakers available. So if anyone has any questions, I'm looking forward to a good discussion of adolescent weight loss surgery. We do have one last question to go up on our audience response, which is the same question you've already seen. Would you consider starting an adolescent bariatric surgery program? And if you'll just answer that one last time, I know I've asked it several times, you can just text the telephone, the code to the answer that you want to give. Perfect. So we'll go ahead and take the questions so people can answer while we're answering questions.
If you answered no way, we'd love to know why. I mean, and I'm serious, because the whole
Come
goal...
to a microphone.
Yeah.
Near you.
Yeah. Not to criticize at all, just curious what the barrier would be.
Hi, I'm Farah Hussein from Portland, Oregon. I had a question for all the pediatric surgeons on the panel in that we are looking at starting an adolescent obesity program. We're co-located at the University Hospital with the Children's Hospital. And I feel like we have fairly good buy-in across the board from the leadership, from the pediatric hospitalists, pediatricians, et cetera. Interestingly, the one group that's supportive of the pediatric surgeons are in that they want to admit the patients for us, et cetera, but they don't really want to be involved in the surgery itself. They really like our bariatric team to take on the surgery full stream ahead and to do all the surgeries at OHSU. So I guess I want to know, what are the major considerations if we were to do that we need to know that we wouldn't be privy to as non-pediatric surgeons? What do you see in the pitfalls of that kind of an algorithm where we are somewhat piecemealing it by doing part of it at the University Hospital and then recovery at the Children's Hospital?
Take that?
You want to take that?
I'll start with that. You know, again, when we were working with the pediatricians, there were a lot of pediatricians that had the exact same situation. The pediatric surgeons were maybe supportive, but certainly didn't want to do the surgery. You know, I think the main issue is going to be for you that you're going to be doing surgery on young adolescents at an adult hospital. And what do the surgeons there do other kids that age?
Anesthesia does ENT cases, trauma, the pediatric therapy for trauma. So they do quite a bit of pediatric anesthesiology at the University Hospital.
I mean, I think if the adult surgery group is willing to work with the pediatric weight management program and certainly, you know, and collaborate in that way and take feedback from the pediatricians, I don't see a major issue with that. But what I might wonder, if the patients are being admitted to the pediatric surgery service, it takes care of some of the cultural issues. I don't have a major issue with that.
I think this is not going to be uncommon, right? I went into pediatric surgery to get away from dead feet, cirrhosis, and fat people.
How did it work for you?
Yeah, how did it work for me?
How'd that work?
But I think a lot of pediatric surgeons, and Tom leaned over and says they wanted to do babies. I mean, that's why we went into pediatric surgery. So part of this is, I don't think it really matters as long as we're doing what's right for the patient. And so that's not only the data collection in a multidisciplinary program, but that we're meeting all of those milestones a program has to have, that the patient is taken well care of.
Yeah, and I was just going to add real quickly that one of the tenets of the American Colleges program and the ASMBS for credentialing is that you have care teams that really know how to understand and identify early rescue when there is a complication. So my only concern for recovering in the Children's Hospital is that's not their strong suit, and you know, probably the acute care needs to happen in one place where most of bariatric care is happening, which is your hospital.
That's a great point. And something I don't think I brought up as well as I wanted to in my talk was the volume requirements are around the surgeon, not the program. And so you do want the patients recovering at a place where the most experienced people can watch them. So I agree with that.
I'm not a pediatric surgeon, but I'll add that I don't think the point actually came out today, and I guess there's some people sitting on the fence that, and I think if you talk to most bariatric surgeons, at some point in their life they sat on the fence. But it's, and it's to the comment earlier about morbid obese patients. But this patient population, as time goes on, if you jump in, will become some of your most rewarding patients. The impact that you have on their lives, and that's what happens. A lot of bariatric surgeons kind of dabble in it, and they realize they get so much more out of looking after those patients and the various other aspects of practice. They actually they gravitate just from the fact that it has a tremendous impact on their families and themselves as well. So,
as an adult surgeon who's been doing adolescent surgery for a while, I can tell you there's two things you need to take into account. One is the liver and the small bowel are different under age 16. They are more fragile, and you have to be more careful. So when you're doing a bypass, anytime you're doing an adolescent bypass, handling the small bowel is different when they're younger. It's like a very old person with diabetes, basically. You have to treat it that way. And I wasn't really prepared for that when I started doing this as an adult surgeon, but that would be, I think, the major anatomic difference that I have found in doing adolescents. The other thing is that nursing is not always happy taking care of young kids, okay? So, if you can board them in the adult hospital and in the children's hospital, if it's, that close and round on them, you're better off, because nursing, child life, nutrition, they educate them and bring them on board with you, you'll be happier. And, we have our hospital was such, it was a pediatric floor in an adult hospital. And so we were able to train the nurses on that floor just like we did in the adult hospital and just round there with the kids.
We have a lot of questions.
I'm sorry,
Yeah,
but real quick,
going.
and children's hospital nurses are not comfortable taking care of 500-pound patients.
That's also true,
But you can teach them.
but you can teach
It's a
them.
rapid fire question and answer.
Yes.
Now, right?
All right.
Go ahead.
Peter Gorecki from New York. I'm an adult surgeon, but we do have pediatric adolescent designation. And, we do have all these talks and conference going on for a couple of years now. And in the big picture of risks and benefits, there's no doubt that in 2018, it's a clear winner for this patient population. The question I have is, what are the societies doing, both SAGES and IPEG, to number one, change the payer view on that, because this is really why the numbers are so small in the country, because simply it is not covered procedure unless you take extraordinary measures and spend a long time with medical directors. And number two, what do you do to educate pediatricians with a more of a kind of intellectual, hesitation to refer the patients in face of such an obvious, benefit to risk ratio?
So I can answer that from the ASMBS. We're fully integrated in the Access to Care Committee, and we've begun developing toolboxes to deal with our Medicaid providers, because at least half of our patients, and that's probably the same way on the podium, are Medicaid patients. In our own state, we're still working on that, but that's sort of what ASMBS is working on. But the Academy of Pediatrics policy statement, if and when it comes out, I think will have a huge impact on pediatricians, especially because this is what they use to practice. The recommendations on vaccinations, change vaccination practices, and what have you. So, and we're hoping that statement will also have an impact with some of the medical directors. But it is an ongoing fight, and several societies are working on it.
The new guidelines also are coming out in SWORD, and we actually published them purposefully without getting a lot of other societies to approve them, because we wanted them to be available for the AAP guidelines to reference. And the idea is that the SWORD publication of the new ASMBS Adolescent Bariatric Surgery Guidelines is an update from 2012, just published last week, I think will be something you can take to your insurance company and say, hey, look at this, these are the new guidelines. And I'm hoping that they're going to be able to change things.
The microphone in the back?
In the back?
Yeah, my name is Mohammed. I am from Buffalo. I have a question for Dr. James. Can we do rings in a adolescent? And for Dr. Parekh, can we, instead of doing a sleeve gastrectomy, can we put only a clip removable, and then we can remove? In that way, we are not changing any dissection, we are not doing any surgery. What do you think? If we put a gastric clip instead of sleeve gastrectomy.
So something that we could undo, a sleeve that could be undone?
Yeah, for example, if we put that stomach, we put a clip, then we,
Oh, clips, right,
yeah,
rather than
then-
staples and division.
That, can we do it?
Do you want to comment about your procedure, David? It's sort of similar a little bit.
Sure. What Max is referring to is we've had some experience with laparoscopic gastric plication. We just completed our 3-year study, a small handful of patients, but the idea is that trying to find procedures more palatable to some of the providers and some of the parents, because it, as you know, and the numbers pointed out at this talk, is less than 0.1% of those that meet indications for surgery come to surgery. So specifically, we've actually had some patients that have done quite well. One that's lost over 154 pounds at 3 years, and all of our patients had great long-term early satiety and hunger control. And the point was made about the plication not working well. I think like the sleeve, you know, it can be done well, it can be done not so well. And there's sort of a fine line between too tight and too loose. And so, particularly with the plication, it is a kind of a fine art to making sure it's just right. So I would just implore all the folks in the room to continue to try to look for other options that may be more palatable to the parents and the providers, because I think the sleeve, albeit it's a great operation, this is not hitting the mark. And I'm not so sure that education is really going to solve that problem.
In terms of the question that came up, though, I mean, I guess having served on a pediatric IRB for over a decade, you know, there's a certain number of people that frown on experimentation in kids. And so until there's a robust evidence base for something like a clip in adults, I would say that, you know, we need to be studying adults.
Don't forget that 60-year warranty.
Well, yeah, again, what I would comment is that it seems like the shift now is more of addressing this problem earlier, right? Instead of waiting until they're 60, even at 11 years of age. You know, some would argue, and maybe in 5 years, we'll be doing it at these operations at 8, right? And 7, when their BMI is 50 or 40. So really, one of the things we thought, maybe even if the plication works well for 20 years, was able to reach, you know, more than 0.1%, something to consider. So I did have a quick question for Mac about his patient. Did that patient get an ultrasound to screen for fatty infiltration of the?
I don't think so. The LFTs were normal. The reason I presented has been sort of controversial about do you routinely do biopsies?
That's my question to you. Do you now?
Right. So I have always done biopsies, both for scientific specimen and the biobank, but also the histology. And I've certainly been surprised over my time of doing this how often you have liver pathology that you would not have known. So that's what I was advocating for.
Do you now screen them all just to be a bit more informed?
Well, actually, we're trying to switch to fibroscanning them, but that's sort of a new technology.
I've actually been doing ultrasounds and biopsies on everyone.
Yeah.
And it's
a lot of them too.
Pretty astounding. And that's under IRB, and we're collecting the liver tissue for future research as well. But it's pretty amazing what a silent but terrifying comorbidity this is.
Hi, Mike Gretzky, Norfolk, Virginia. First, wonderful panel and talk. I learned a lot. In disclosure, I don't do bariatric surgery yet, but it's programmatic questions. So for all the pediatric surgeons, for everyone in the room, this is probably the largest, you know, bariatric surgery pediatric surgeon. So the first question is, how many cases are you guys each doing a year now? And that's the number question. As a place that's looking to start a program is, what are going to be the recommended numbers? Because as a pediatric surgeon, my adult counterparts next door in 2 weeks will do more than I can possibly hope to do in a year. So what is the challenge for a lot of places? It's one thing, you know, if you're a pediatric surgeon working in a big adult hospital and you have bariatric surgeons. But if you're in a place that doesn't have bariatric surgeons and you're not part of a big umbrella of an adult place or academic of a place, how do you get the mentoring? What is the proposal mentoring? Because the money comes into it. So how much do you pay the mentor? What is the going rate? These are questions that are coming up that people are making up the numbers, so it'd be nice to know what other centers have done to get the appropriate mentoring for 2 cases, 20 cases, 50 cases. You know, those are kind of practical things.
Yeah, those are great questions, and we struggle with them still. I'm in pretty much the same position you are. Our community bariatric surgeons are in private practice and really shy away from kids because of malpractice reasons, if nothing else. I have to admit that I turned to Ethicon when I started, and they actually have a program for helping pay for mentors to come in and there's a going community rate. I think it was around $3,000 for 2 cases a day. We did 5 at our hospital with the mentor, but I also did 10 additional cases at the adult hospital before I started. You know, the volume issue is a huge one. I think most of us are probably doing in the 15 case a year range rather than the 25 case a year range, which MBSA QIP requires. And that's going to become a barrier to the existing programs and certainly a barrier to new programs. So that number is probably, and I say probably because we're still early in the discussions, are going to come down to more in the 15-a-year range. But the important thing is, for anybody who participates in NISQIP, you know, we're going to do a case-by-case review so that we'll know fairly quickly if there's a center that's having problems and we can relook at them and put them on probation. The reality is if you don't reach the volume numbers right now, to be an MBSA QIP center, you have to have a co-surgeon who is a verified surgeon, so you would have to have that cooperation. It's tough to do in an area where you don't have any adult bariatric surgeons, but I would encourage at least 10 or 15 procedures with an adult person before you go, and to make sure that you're, as most of us are, pretty capable advanced laparoscopic surgeons otherwise.
I would say that I think actually this is probably the only person in the country that, as a pediatric surgeon, meets a lot of the requirements. It's really about going back to doing what's right? So you have to have, in my opinion, an adult bariatric surgeon who's doing those hundreds of cases but is missing the psychosocial piece and the ability to deal with families and all the other things that happen with children and adolescents. And you become a partnership, and that's a negotiation. But I think it's an imperative for virtually every pediatric surgeon in the country that if you're going to do this, you must have someone who's your partner. I work with Vadim Sherman, who's at Methodist Hospital in Houston, and he gets the 2 o'clock call in the morning when I'm like, is this supposed to happen on post-op day 4? Because I will never see the volume that he does. And so I think that that's a very important thing. Even if it's hard, you have to figure out what it takes to have that partner.
And I think that everyone's skill set coming into this differs, and depending on your skill set in advanced laparoscopy and foregut surgery as a pediatric surgeon, it may be 5 cases. The more important thing, I think, in addition to ascending the learning curve and also appreciating the fact that a sleeve gastrectomy is not just whacking out 80% of the stomach. It is a technically precise operation.
And I think 5 is way too low.
No, to keep the to do the operation correctly, it's technically it's more sophisticated than a lot of people appreciate. But I do think also it's not just that technical in the operating room part. It really is this postoperative care and having enough to know when you worry.
Jeff Seitz from New York. Congratulations. I thought this was a great panel, and I'd like to thank you all in the program committee for putting it together. A comment and 2 quick questions. One comment was that in Mark's presentation that Janie gave, I didn't see anything about thiamine deficiency as a case, and we've had several cases following sleeves who have developed symptomatic thiamine deficiency, so that's important to monitor and to treat aggressively if they come in and suspected. The question is, number 1, Janie, what happened to your patient as far as his hyperphagia and appetite after the surgery?
So he still has an appetite. He has not been hyperphagic, and I don't know if that's going to go away, if the restriction, because we're only 2 months out, will go away. His appetite, he says, is less, though. He says he's not as hungry as he used to be. But I don't think it's completely cured.
And the other question is that when you look at the 3 operations, I'll exclude duodenal switch operations that were presented, it's a little bit like looking at Waze or Google Maps, that sleeve is an hour, bypass is an hour. I can tell you band is about 3.5 hours, so very few people are going to take that route, not in terms of the operating time, but just in terms of choosing which to do. And so the guidelines support that. But how do you choose between a sleeve and a bypass in somebody who doesn't have symptoms of reflux?
For our patients, it mostly is a it's up to the patient to some extent. Like I've had, as having been an adult surgeon, I have patients that come in whose parents had a bypass and they want a bypass and that's all they want. And I would not say no to that because, again, I don't think we have enough long-term data on the sleeve to say for sure that's a better operation than a bypass. On the other hand, if the patient comes in and says they absolutely want a sleeve and there's no contraindication or reason to believe it would be better, then I'm fine with doing a sleeve. You're not dealing, it's not like in adults where you can say, okay, if you've had diabetes longer than 5 years, you probably should have a bypass, or longer than 10 years, or whatever your cutoff is. Most of the kids have not had diabetes for that long. So I think, and the weight loss, as you saw from the data from Teen Labs, is the same for a sleeve and a bypass. So you don't have a lot of reasons to do a bypass over a sleeve, except for reflux. So that's from my perspective.
I'll do the
She has the other option.
I have the other extreme. So I'm still very, very concerned, as I was for the band initially, about the physiologic effects on the esophagus. And so I have...
Of the sleeve.
Of the sleeve. And so I've stayed with the bypass because it's the one that we have the most data on for the longest term. And there are downsides, no question, but they're manageable. What I'm worried about, and again, this goes back to, there's not a right or wrong answer, we just don't have all the data yet. If we're really looking at the incidence of Barrett and esophagus, and that translates into the percentage of carcinoma that it will, we may end up with a small epidemic of people with esophageal cancer in their 30s or 40s. And we're not going to know that for another 10 or 20 years. So that's my concern. It may not be valid, but we don't know.
Jeff, to quote my friend and colleague, Dr. Alan Posner, who's standing in the back there, if you are interested in the sleeve, that's fine, but you also have to be willing to have a bypass. So the answer is we offer both sequentially if needed.
And in follow-up to Mary's comment, I'll congratulate Janie for bringing this issue to the fore in this meeting. I'm very worried about the Italian data that suggests in a small study, and we need to see your application, but that the incidence of Barrett's in patients with without symptoms of reflux may be much higher after sleeve than we know about, and we don't really know the incidence of Barrett's at baseline in teenagers that are coming to us for weight loss surgery. I was referred a patient recently for a Nissen and considered her for bypass with Barrett's, so it does happen that they're developing Barrett's, and we don't know the incidence because we're not looking.
The issue of Barrett's is very topical, and there's people that say reflux or Barrett's is a contraindication of sleeve gastrectomy, and then there's others that don't, and then you get into anatomical considerations, patients' wishes, severity of esophagitis, and that really is the subtlety of the discussion. It's GERD or Barrett's esophagus by itself. I'm always concerned. A big part of what I do is manage Barrett's esophagus, as far as dysplastic Barrett's, and what's changed in that in the last 10 years is that when I was 10 years ago, esophagectomies were common for multifocal Barrett's, high-grade dysplasia, and intramucosal adenocarcinoma. And in our own personal experience, we haven't done an esophagectomy for that for 10 years. So, what happens is not only is everything's changing, the management of Barrett's esophagus, dysplastic Barrett's, the options for there are so much better. And so what happens, people say, oh, Barrett's esophagus, that seems like a death sentence. I'm not so sure Barrett's esophagus is a death sentence today. And so it needs to be considered, but I think there's actually bigger issues like the anatomical and patient wishes and that drive that discussion, basically.
I'm going to make one other comment there because I trained in Canada and the system's very different. My 19-year-olds, when they lose their insurance, are not going to have any follow-up until they develop the cancer.
So you're going to give them a bypass because they're over a sleeve for that reason because they don't have follow-up?
No, that's a good, valid.
Oh,
that's back
in the back.
Yep.
It's good.
Hi, Abdullah from Qatar. So I did my first lap sleeve in 2008, and meeting the criteria that everyone's proposed, we end up doing maybe 4 or 5 a year that are solid indications, liver cirrhosis that we reversed and so on. But increasingly there are a number of children that have had complex neurologic surgery or issues, and they're hyperphagic. So I've had 2 kids come to me when they're 10, 11-ish, and they have lost the ability to walk because their BMI was 55, 60, now 68. And I'm hesitant to break the rules, and when you're doing 2 failures a year is a big deal. It's kind of the right thing for the patient, but you have had 10, 15 years of experience with the pediatric patients. We tell them, you're going to fail the sleeve or the bypass. Is that real? Or do you just say, I don't care anymore, you've lost the ability to walk, you have skin breakdown, you have other issues going on. Don't wait till they're 15, 16, skeletally mature, and so on. I know Hayed from Saudi says, you guys are all crazy, he just does the procedure. And his results are quite good, right? I mean, he publishes them and so on. But when you have someone that they're dying in front of you, do you just break the rules and go ahead because you guys have more experience in this, and I haven't yet broken the rules in a sense? None of us pretty much do. I think the only people that do are just in Saudi, and they're very good at it because they've got a big center. But what do you do with those kids? And this is specifically to the children. It is not the 18-year-old. It's the 11, 12, 14.
Tom, you've had a long-standing interest in hypothalamic obesity.
Yeah, I mean, this is a big topic, and I'll just say that I think we have to, when there are soft rules, none of these are hard rules that you're saying to be broken. I think we have to go back to our basics, and we have to look at each individual patient, each individual family, and realize that what we're here to do is help people. I myself have operated on one 8-year-old with hypothalamic obesity in the proper, what I considered the proper setting. An endocrinologist that was very invested, a family that was very invested, and looking at IED's data, I guess you would have to say too. But I think we have to really realize this is individualized care at that point.
Do they gain weight after? Because that's the problem is you tell them.
And again, the other big part of this conversation we haven't had yet is pharmacology. And I don't think it's all or none. I mean, I think that there's lifestyle, there's pharmacology, there's surgery, and then there is the application of all of the above. And in some of these patients with just the most god-awful, terrible problems that we could never imagine, never want anyone to have, that they have, we have to pull out all the stops.
I actually am toying with a prospective trial because 100% of kids that get treatment for thalamic tumors develop this, right? It's a straight shot like this.
Yeah, and they're surviving now.
And they're surviving. But they all go to, and I'm actually toying with sort of the iatrogenic bulimia from this idea of putting in a G-tube and using the Aspire that's been used in Europe. I don't know if it's approved now. I'm sure it's not for kids. But that's putting a G-tube in, So I really hope maybe that'll be the next step we'll do is that prospective trial to show how to prevent that inevitable morbid obesity up front for those kids, because it's just a terrible no-win situation once they get fat.
Let's go to the back microphone one more time. She's been waiting, and then we'll come here quickly.
Hello, I'm Astrid Suarez from Puerto Rico. Hopefully, I'll be performing bariatric surgery in Puerto Rico. I did a fellowship with Dr. Mark McCaskill last year. That was wonderful. My concern about the long-term outcomes of Barrett's esophagus in the pediatric population that will be adults in 20, 30 years old in advance. And yesterday there was a very interesting panel in SAGES about gastric sleeve and GERD. My question is, should we be performing pH metries and manometries in all the adolescent population as a part of the preoperative work?
Reflux expert here.
I do preoperative endoscopy in all my adolescents, and I think it is very helpful. We find a lot of H. pylori, and we treat it. And we've had a couple of severe eosinophilic esophagitis that we also treat before.
I do the same.
And this year I started doing the same as well.
I think certainly a reasonable thing to do is again, it's oftentimes interesting to look at the what they're doing in the randomized control trials to kind of formulate our thoughts. So in in the SM BOSS, they did manometry, upper GI, and gastroscopy, as well as an ultrasound. But in sleeve pass, it was gastroscopy and so with no standardization of gastroscopy, just kind of gastroscopy and subjective assessment, but no manometry, and that's a randomized controlled trial. So the answer is there's variations on what constitutes standard of care, and and then when you get into making clinical decisions, there's resource issues as well. So certainly, I personally don't test everyone up front, in part because I have a bias. I feel like I'm comfortable managing the things on the back end. But other people like to do all the testing up front, and I think that's a perfectly reasonable strategy. And if you have the resources, absolutely go for it. But if that becomes the reason you can't get your program started because you don't have the resources, then maybe that's not a good idea to do.
Okay, probably our final question since we've gone over time.
Okay, I'm Dr. Kelly from Mexico. We allegedly, we have the gold medal of adolescent obesity in the world. I don't know if that's true or not, but I'm a high volume bariatric surgeon for adults, and I take 2 or 3 cases per month of adolescent surgery. And my procedure of choice is the most revisable, since we are going to be screening these patients for GERD for 60 years, and I don't think I'm going to be around for the next 60 years, maybe my son. I go with the most, it's a basic approach, but I go with the most revisable surgery, which is the gastric sleeve. If you are not if you don't do good with the Roux-en-Y, you're stuck with it. There's nothing else to do. So I go with the more revisable surgery, which is the gastric sleeve. That's all I have to say.
Thanks, everybody, for participating. It's been a great session. Thanks to all the panelists.